Let me have the pleasure of introducing Dr. Mala DHARMALINGAM. She is a well-known endocrinologist from Bangalore. She had an extensive academic career at MS Ramaya Medical Institution. She will talk about insulin resistance. Please, madam.
So very good afternoon to all of you. It's my pleasure to be here, and I thank the Trendo team for having given me this opportunity to present a very interesting topic called severe insulin resistance, diagnosis and management. So over the next 20 minutes, I'll take you through what is, how does it go in this? Okay. Through what is the definition. First and foremost, we need to understand what we do we call severe insulin resistance. I'm not going to talk about what you normally see in your own clinics of insulin resistance of type 2 diabetes. This is severe insulin resistance. Then we look at what are the causes of it, how to diagnose, and then of course management and few take-home thoughts of conclusion. So what is insulin resistance? So if you look at a definition, a state where more than normal insulin is required to elicit a quantitatively normal response. So supposing you expect 1 unit of insulin to bring down the blood glucose by X amount, here you would have to do X by N, then only you will get that amount of blood glucose reduction. So the amount of insulin required is much higher. The other definition is it may not always be diabetic. So if your fasting insulin is around 50 to 70 microunits per ml or post GTT, the peak of it is more than 350 microunits per ml, then it suggests severe insulin resistance, or a place where you require more insulin, or there's more insulin in the body which is picked up with a fasting sample or a peak GTT sample. Now if you look at the spectrum of what is severe insulin resistance, it's very interesting to note that in the first of here, I'm sorry, this pointer is not working, you have the non-diabetic whose BMI is less than 30 and where the fasting insulin is more than 150 picomoles per liter, and peak insulin on oral glucose, this is in picomoles. So what I had told you earlier was in nanograms. And then absolute insulin deficiency, BMI less than 30, where your insulin requirement, which is exogenous, is more than 3 units per kg per day. So some people say 2 units, some people say 1 unit. This is one of the definitions which says that severe insulin resistance is when your requirement of insulin is more than 3 units per day, per kg per day. Then of course you have the run-of-the-mill insulin resistance, which you and I see ample amount of times in our own clinic, which is the partial beta cell decomposition. Here, the person is overweight, his BMI is more than 30, but this is a little difficult because there are a lot of factors which go and overlap each other, so you don't know that insulin is really a cause of obesity or it's actually a requirement. So this insulin levels are difficult to interpret because of the obesity-related insulin resistance itself. There may be glucotoxicity, and there's impaired islet function, and also you may have already started insulin, so there will be exogenous insulin as well as endogenous insulin, which causes the insulin levels, if you measure, to go up. Of course, we can't measure we can measure C-peptide levels in them, but again, the C-peptide may come wrong if the blood glucoses are very high. So, however, what should prompt you to think that this is insulin resistance is if you have acanthosis nigricans, ovarian hyperandrogenism, or lipodystrophy, then you should think about it. So if I look at the causes, what are the causes of severe insulin resistance? These syndromes are very important. Type A, this is because of insulin receptor gene defects. These are from birth. So the type B is also insulin receptor, but it is autoimmune. It is due to antibodies to the insulin receptor, which causes the type B kind of insulin resistance. The first is genetic, the other is autoimmune. Type C, or sometimes it's not classified into any type, is Hair-An syndrome. Why it is not classified? Because it has a genetic background. It also has an environmental background. So Hair-An stands by itself. And of course, apart from that, you have a lot of medications which can cause severe insulin resistance. You have a lot of endocrine disorders which can cause severe insulin resistance. And you have anti-insulin antibodies, which is what we see if you give. Earlier, we used to see when we are giving bovine insulin, porcine insulin, antibodies to insulin, and so on. And then you have physiological causes, and then you have pseudo-resistance, and you have HIV-associated lipodystrophy, and you have lipodystrophy itself, which can cause insulin resistance. So let's look at some aspects of what can go wrong in the insulin receptor gene itself. So you can have synthesis problem, which is called a class 1 defect. You can have the interfere with the intracellular trafficking, which is the class 2 defect. Decreased insulin binding, class 3. Impaired tyrosine kinase activity, class 4. And if the insulin gene gets degraded very fast, that is called class 5. So now if I have to look at a picture, all of you are aware that this is the insulin itself, which has got the alpha chain, alpha and the beta subunit. And of course, this is the signaling pathway. So if the insulin alpha and beta, whatever is in red, if you see, that is the defect. So if this alpha and beta get damaged, you would have the very classical syndromes of Rabson-Mendenhall, Leprechaunism, or Donahue syndromes. And if this PI3KP85 gets damaged or there's a mutation over there, you would actually get the short syndrome. And if you have this AKT, this is the interesting part, the AKT2, where if you have a mutation at that level, what happens is this mTOR pathway is stimulated instead of going into FOXO, and now they know this mTOR is also responsible for de novo lipogenesis and actually the fatty liver. Earlier, we were not knowing that why this fatty liver was happening, but this is one of the reasons why NASH, which is again NAFLD, is a reflector of severe insulin resistance. So the other cause why there is severe insulin resistance, usually when insulin receptor is, the stimulation happens or the signaling happens, it is the tyrosine kinase which actually gets activated and the signaling goes on. But if it is due to serine phosphorylation, then the insulin receptor substrate proteins, they become much more insulin resistant if the serine phosphorylation happens instead of the tyrosine kinase phosphorylation. And these are all different reasons why the serine phosphorylation will happen rather than tyrosine kinase phosphorylation. So now if I look at insulin receptor defects, you can have 0% up to 50%, and the 0% are the classical type A, where you have the Donahue syndrome, which earlier we used to call Leprechaunism, then you have the Rabson-Mendenhall, and then of course the type A insulin resistance and the HARAN. And because it's all congenital, you will have growth retardation, soft tissue overgrowth, hyperandrogenism, insulin resistance, diabetes mellitus, and impaired development of skeletal muscle adipose tissue when there is absolutely almost zero residual insulin receptor defect. So let's look at what are the factors, or how clinically can I differentiate type A, type B severe insulin resistance. So basically, how will they present? They can present with hyperglycemia, they can present with hypoglycemia, hyperandrogenism, acanthosis nigricans, acropachy, NAFLD in fact. So all of these are reasons how they will present to you. So it's our clinical acumen to understand what they have and treat accordingly. So if you look at this is type A and this is type B. Type A, like I told you, it's genetic, so there is early onset, and features of insulin resistance are very, very obviously present. Type B is mostly autoimmune, so it occurs somewhere around middle age, and of course features of insulin resistance will be there, and features of autoimmunity also will be there, where you have vitiligo, alopecia, arthritis, nephritis, all other autoimmune problems will be there. So this is a girl with typical HARAN syndrome. You can see the severe acanthosis nigricans, acanthosis nigricans for her, and yeah. So this is a person with Rabson-Mendenhall syndrome. They will present with dental dysplasia, premature aging, acanthosis nigricans, large amounts of insulin, and poor prognosis. This is the Donahue syndrome. They'll have abdominal distension, inguinal hernia, large hands and feet, and basically the defect is at the alpha subunit of the insulin receptor. So this is one case where this was Donahue syndrome, leprechaunism, cause facies pigmentation. This is not my case. This was picked up from the internet. And cause face and pigmentation. And if you see here, patient has hypoglycemia alternating with hyperglycemia. So they had fasting hypoglycemia, but they had extreme hyperinsulinism, and the defect was there. If you look at C-peptide and proinsulin levels, they are very, very high, suggesting severe insulin resistance. So this is another type A resistance, insulin resistance, where the birth, here you can see almost similar presentation. Grandmother had diabetes. This child was symptomatic for hypoglycemia for 10 years, then had oligomenorrhea with cosmetically distressing hirsutism at 11 years, and then 75 grams showed fasting hypoglycemia, and then the blood glucose went high. See the amount of acanthosis at the axilla, and then the typical polycystic ovaries at the, when we did an ultrasound scan. So this is how a person can also present when they have type A resistance with polycystic ovaries. So you can't think all persons who present with polycystic ovaries is the run-of-the-mill polycystic ovaries. So if they have severe insulin resistance, and they are also, especially if the BMI is not very high, you should think, are we looking at something else? So this girl at 17 years had fasting hypoglycemia, insulin-resistant diabetes, and then, however, the blood glucose kept going higher. And how do you treat them because of so much insulin resistance? This girl was given IGF-1 for 4 months, which was complex to recombinant IGF-BP3, and did well with time, again, from the internet. We, in our own, and this giving IGF is not so easy. It requires a lot of expertise, and that's how her sugars and all came down, and she didn't have any fasting hypoglycemia. So these are some of the clinical features. You can get acanthosis nigricans. You can get axillary acrochondrons. Those are small growths over there at the axilla. This is the abdominal skin flexures. This is actually an insulin receptor mutation, congenital lipodystrophy, and this is papillomatosis. When you do a skin biopsy, you would find papillomatosis like this in the acanthosis nigricans region. So this is again polycystic ovary. So patient can come with PCO, but actually has an insulin receptor defect. And this was a defect in the PPAR gamma. If you see the enlarged ovary and also the enlarged fallopian tube, and which was then, when histopathology was done, it showed ovarian sclerosis and hyperthecosis in histopathology. So a person with an insulin receptor gene defect can come with typical polycystic ovaries with everything suggestive that it is polycystic ovaries. And of course, after type A, we have type A and type B, we have lipodystrophy, which is a huge chunk of severe insulin resistance. It's very, very difficult for me to go through the whole of lipodystrophy in the short time that I have of 20 minutes. Just suffice to say, lipodystrophy, you have to suspect when there is loss of fat, subcutaneous fat. It may be partial or it may be generalized, and it can be congenital or it can be acquired also. So if and both of that can be generalized as well as it can be partial. So lipodystrophy is something also which we do see quite frequently, and we need to suspect so that we can evaluate and treat correctly. So these are the what are the clinical features and how to have a suspicion. So you have to, the most essential feature is you should have absence of body fat. It could be generalized or it could be partial. And of course, you'll have physical features suggestive of insulin resistance, like acanthosis, eruptive xanthomata. They may have Cushingoid and acromegaloid appearance. Again, even acromegaloid, which was earlier thought as a separate entity, now comes under severe insulin resistance. So you have, and then you can have them requiring large doses of insulin, more than 200 units per day or more than 2 units per kg. Like in the beginning, I told you there are definitions which could be 3 or 2 units, and so on. So now let's look at labs. What would be the lab to tell us where is the problem? So here you have insulin signaling defect, there you have lipodystrophy, and here you have simple obesity. So basically, there is a lot of overlap between all the three, but if you look at insulin signaling defect, basically the IGF-BP1 will be normal and the SHBG will be normal, but the adiponectin will be high. Some of them are common. In lipodystrophy, the leptins will be low. And of course, obesity, we know that adiponectin will be low, there will be NFLD, increased BMI, and so on and so forth. And this is how you would diagnose lipodystrophy based on history, physical examination, no defined leptin levels to say which it is, whether it's a lipodystrophy to rule it out or confirm. And of course, genetic testing has to be done, and I think that is the way forward. In our country, we do very little molecular genetic testing because it's so fearfully expensive. So we need to have labs which we can go to, which are cost effective, and I think that's the requirement. And this is the flow chart for lipodystrophy. If you suspect, take a careful history, physical examination, then the anthropometry. If they have progeroid features, then you suspect genetic lipodystrophy, genotyping, and then you take a pedigree chart. If there's no family history, then you see what happens at birth and then late childhood. Then what about the fat loss, whether it's extremities, upper body, generalized, and then you can suspect acquired lipodystrophy. And if it's autoimmune disease, also we can suspect acquired lipodystrophy. Now, this was a very interesting case, which I thought I should. This is insulin antibodies. This is not type B. This is separate. This is insulin antibodies. So here you should know there are antibodies to insulin and there are antibodies to insulin receptor. Receptor is called autoantibody, like the GAD autoantibody and things. But this is the insulin antibody. Supposing person has received some other source of insulin, which used to happen earlier, then you call that insulin. 920 units per day was the requirement. Insulin receptor antibody was not found, and the insulin antibody was 8.7, where the normal is less than 0.4 units per ml. This patient was treated with immunosuppressants like steroid, rituximab, and mycophenolate, and then the antibody titers came down and the blood glucose also came down. So you can see through time, through the 4-5 days, the glucose has come into control. So now management, just touch a little bit of management. Basically, this is one scenario where a concentrated insulin of 200 IU per ml or even 500, though it's not available in our country, IU per ml will really be useful because they require a large amount of insulin. And this is the flow chart to say how much you will give if it is requiring 200 to 300, 300 to 600, how to give it 3 times a day. And whoever is interested in this detail can take this slide from me later. And this is for those who require more than 600 units per day when you have to give 4 daily injections, and this is the percentage that you would give it. What about other drugs apart from insulin? The other options that have been tried in severe insulin resistance is GLP-1 receptor agonists and metformin, and there are some have not been evaluated but may be a good choice, which is SGLT2 inhibitors, DPP-4, TZDs, sulfonylureas. Anything which actually controls the glucose will reduce the glucotoxicity and therefore will reduce the insulin resistance also. But they are not yet tried in the severe insulin resistance cases, but worth a try. So now what is my diagnostic approach to say that this is a case of severe insulin resistance? So what are the signs? Is there ovarian dysfunction, acanthosis nigricans, skin tags, hepatosteatosis, dyslipidemia, or fat loss? Then if they are normoglycemic, and if the insulin levels are very high, then I should suspect an insulin receptor defect. And if there is no insulin resistance or the insulin, fasting insulin is normal, then I should think something else and look for that. And if they are diabetic and if they are requiring more than 3 units per kg body weight per day, then you look at lipid profile, adiponectin, and then see if they have an adipose disorder or just obesity or it is lipodystrophy. And of course, refer to a specialist to further subtype them so that they can be treated correctly. So last case, which is a question to the audience. This is a 14-year girl with diagnosis of type 1 diabetes, family history of CVD, required 170 units of insulin per day. Her BMI is 20 kgs per meter squared, no subcutaneous fat. Investigation, C-peptide is 25.2 nanograms per ml. So who is going to tell me diagnosis? The first row? Yes. So lipodystrophy. I have shown in the first slide that this was LMNA mutation is very common in the congenital as well as in the acquired, and this is a patient with familial partial lipodystrophy with secondary diabetes. So for the students here, for the postgraduates, type 1 diabetes, many times we think that this is only type 1 diabetes, cannot have a differential diagnosis, but a type 1 diabetes can be a familial partial lipodystrophy. It is important, once the sugars are controlled, to do a C-peptide for all of them to understand, are we really dealing with type 1 or we are dealing with something else. So my conclusion, severe insulin resistance syndromes is usually present in the obese, can be also present in the lean, and SIRS can present with other comorbidities like hyperandrogenism, NFLD, diabetes, and dyslipidemia. So it's very important that we are able to have a high degree of suspicion and do look for all of these clinical features and take it forward. And it can be differentiated by careful history, biochemical, genetic, and immunological testing. And it's important to diagnose because now we have actually medications. Now people have tried metreleptin for lipodystrophies. So there are some medications available which we can use to control these deficiencies. Thank you very much for a patient hearing.
Thank you, ma'am. Thank you very much for the wonderful presentation. We'll have the questions at the end of the 3 sessions. After all the 3 resistances are over, I request the audience to note down the questions so that we can ask them later.
Good afternoon. I think I'll start the second talk with a personal anecdote. About 6 months back, I had a case, both T4 and TSH very high. I had a big fight with my laboratory about how they are not doing their job properly, and they repeated the test, and to their surprise, it was the same test, the same result was reproduced. So then I thought I'm dealing with a case of thyroid hormone resistance. And a month later, another patient, first time it was a lady, second time it was a male, similar findings, again T4, TSH, both high. So in further history taking, it turned out that they are brother and sister. They come independently without each other's knowledge.